Laparoscopic treatment of intestinal obstruction in a 22 plus weeks pregnant woman. Intestinal obstruction in pregnancy is a rare condition. Incidence is 1 in 2,500 to 3,500 deliveries. Maternal mortality is 6%, which is higher than general population. Fetal mortality is reported as 26%. Increased maternal mortality is due to delay in diagnosis and treatment because of reluctance to do radiation-based investigation and to operate on pregnant women. The main cause is adhesion, and it is followed by volvulus, interception, hernia, carcinoma, and appendicitis. Patient might have abdominal pain, nausea and vomiting, fever, history of previous operation such as appendectomy. Physical examination might reveal abdominal tenderness and distension, increase or decrease bowel sounds. Investigation might show leukocytosis, electrolyte abnormalities, air fluid levels on ultrasound and CT, but diagnosis is usually made by history and physical examination in the majority of patients. Treatment is midline vertical laparotomy. There was no article found in the literature review about the laparoscopic treatment for intestinal obstruction due to adhesion during late second trimester of pregnancy. Laparoscopic treatment of intestinal obstruction is considered as a relative contraindication even for general population. But there was a good review paper published in 2012 about the laparoscopic treatment of small bowel obstruction in general population. There were more than 2,000 cases. Adhesion were the most common etiology, and nearly half of them were single band adhesion. Conversion to laparotomy was due to dense adhesion, bowel resection, unidentified pathology, and iatrogenic injury. Overall conversion rate to midline laparotomy was 29%. When the etiology was a single band adhesion, the success rate was around 75%. Morbidity was 15% and mortality was 1.5%. The enterotomy rate during the operation was 6.6% and majority were recognized during the operation. Laparoscopy was associated with reduced morbidity and length of hospital stay as expected. Laparoscopic treatment can be successful, those with mild abdominal distension, proximal obstruction, partial obstruction, and anticipated single band obstruction. This was suggested in one of the paper. This is a 35 years old, 22 plus weeks pregnant woman, G2P1 with the history of cesarean section and appendectomy. And she was presented with the history of intermittent generalized abdominal pain and nausea for 3 days. Physical examination revealed generalized abdominal tenderness and no rebound tenderness. Uterus size was corresponding to her gestational age and fetal heart rate was positive. After consulting with colorectal surgeon, she was admitted and IV fluid, broad spectrum antibiotics, analgesics and antiemetics were started. All investigation results were unremarkable. Following day, her symptoms rapidly became more severe and she was not responding to multiple antiemetics and opioid analgesics. She has also developed rebound tenderness and abdominal distension. After consulting with colorectal surgeon and counseling the patient, decision was made to take patient to operating theater for laparoscopy and plus-minus laparotomy. Orogastric tube was inserted to prevent injury to stomach during left upper quadrant entry. Foley catheter was placed in the bladder. Thromboprophylaxis is achieved by pneumatic compression device. Nifedipine used as a prophylactic tocolysis, even though we don't have enough evidence to support that. Patient positioned in a low lithotomy and a wedge put under her back on the right side to avoid any significant compression of the aorta and inferior vena cava. 5 mm trocar was inserted under the direct vision on the mid-clavicular line 2 cm below the costal margin in the left upper quadrant while abdominal wall elevated. Intra-abdominal pressure kept around 10 to 12 mm mercury. Fetal heart rate was confirmed before and after the operation. Laparoscopy revealed single band adhesion, which was divided laparoscopically. All other intra-abdominal organs did not show any significant pathology. She was rapidly recovered after the operation, and rest of her pregnancy and delivery was uneventful. Therefore, laparoscopic treatment of intestinal obstruction in the late second trimester pregnancy is both feasible and safe. It may be possible in some cases. And this is the video demonstration of this operation. You can see the 5 mm trocar higher and lower level on the left lateral side, and you can see the single band adhesion. And it's divided by using harmonic scalpel. And also there was another 5 mm trocar on the right lateral side around the umbilicus area. And it was bipolar diathermy used for hemostasis. And you can see there on the right side tubes and ovaries look normal. Adnexia was checked to rule out any mass and torsion. And this is the right side tubes and tube and ovary, and bowel being inspected, and behind the uterus also inspected to rule out any pathology, and bowel being checked to see any segmental ischemia or any pathology, and all the bowel segment inspection look normal. And you can see the stomach and gallbladder and the liver. There's a nodule there, which is an hemangioma, which was indicated on the ultrasound report. And it's a bit dark now, but we're looking at the between the fundus and the anterior abdominal wall. And we are looking at the left side of the abdominal cavity. And as I said, the whole inspection of the bowels look normal. There wasn't any ischemic segment, most probably due to early diagnosis and treatment.